My name is Aaron Reeves. I'm an Associate Professorial Research Fellow here in the International Inequalities Institute, and it's my great pleasure to welcome you to this afternoon's session, which is going to be on health equity and health inequalities. I'm going to introduce all of our speakers at once at the beginning so we can just kind of move straight through and then have ample time for questions and answer at the end. But really the purpose of today's session, or this afternoon's session, is to think about, in the context of some of the other conversations we've been having about the relationship between health and other forms of inequity and injustice in our societies. We're going to move internationally across three very different settings. We're going to think about those issues around health at different levels of society too. So hopefully will be quite a rich and fruitful conversation. But let me introduce our speakers. First, we're going to hear from Chuck Collins, who is a senior scholar at the Institute for Policy Studies. Chuck's most recent book is Born on Third Base, A One Percenter Makes the Case for Tackling Inequality, Bringing Wealth Home, and Committing the common good, to the Common Good. We're also going to hear from Professor Mvoyo Tom, who has just retired actually as the Vice Chancellor of the University of Fort Ha, and is currently the Deputy Chairperson of Takano Health Equity South Africa. And then finally, we're really thrilled to be able to hear from both Anne Rathbone and Simon Duncan. Anne is a Senior Training and Consultancy Manager as part of Boing Boing, which we'll hear more about. And Simon works for Boing Boing as a trainer on the inequalities and resilience approaches. So without any more time from me, if you could just join me with welcoming all of our speakers now.
Thank you, Aaron. Good afternoon. What an amazing session we just sat through. I don't know about you, but I found it incredibly moving. And to have a discussion about health equity, if you think about it, what could be more intimate? These are our bodies, our minds, health, and our ability to have access to health care when we need it, how important that is. As Aaron said, I grew up in the 1%. I grew up in a wealthy family. And one of the connection points was that I have a brother who struggled with his mental health, who had to depend on public mental health services. And there were members of my own family who consistently voted against tax increases and tax levies until they understood that this was something that helped everyone, including their nephew or their son. So I actually think health equity is a window, it's a portal into these larger issues of inequality because most people can relate to it. It helps us sort of disrupt some of those mythologies of deservedness that I think hold these inequalities in place. So I'm excited to be to have this discussion. And I want to just give you the sort of quick high points of what I want to talk to you about. I'm here really to talk about the United States and the struggles around health equity and the impact of Trumpcare, what's called Trumpcare. But I want to set the context by just talking about the U.S.'s zigzagging path to try to move towards some kind of universal health care, and how a lot of the innovation comes from states and localities, and that theme will continue. That whatever progress, though, we've made towards health equity and universal health coverage is at risk because of the current proposals before our U.S. Congress. I want to talk to you about the drivers behind the move to repeal and replace Obamacare. One of those drivers is ideological. Another has very nothing to do with health care. It has to do with tax cuts and tax policy. And finally, I want to talk a little bit about the scenarios going forward and, again, how states are going to play a critical role. So that's a little bit of the overview. And let's see. Okay, apologize, my first two slides are a little scrambled here, but let me just say I work at the Institute for Policy Studies. I invite you all to visit our website, inequality.org, which is a portal for commentaries. You yourself may have a commentary to offer us. I want to introduce my colleague, Sarah Anderson, who we both came from the United States. Sarah is really one of our national experts on the whole issue of executive compensation and the growing disparity between CEO pay and average worker pay and what to do about that. She's also been part of a number of international coalitions with some of you on instituting a financial transaction tax. Most of the work I do is around tax policy and looking at the overconcentration of wealth and how that distorts pretty much everything we care about. And I'm particularly interested in sort of issues around hidden wealth and, you know, where is all this wealth going that's not just offshores, but in trusts and family offices and other mechanisms like that. So that's a bit about our work. And I would just say the context is somewhat good news, which is, having worked on this for 22 years, there's growing recognition that these inequalities matter, that they matter to public health, that inequality is making us sick, and that is something that touches people at all income and wealth levels, that there's a breakdown of social solidarity, and that undermines the quality of life for everyone, including public health. And so I think that there's a growing recognition of that. There's a tremendous amount of sort of research and practice around understanding the social determinants of health and addressing that in practice. And a lot of the innovation is in state and local health centers. This is another scrambled slide, but just as a definition, I want to say health equity, and this is actually from my own neighborhood health center. Health equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environment, and health care. And if you think about what the panel we just heard, barriers to belonging perhaps is another provision or something that we should include in that definition of health equity. And when we want to really measure our achievement or advancements in health equity, we're really looking at how health equity is reducing and ultimately eliminating disparities in health and its determinants, particularly as they affect excluded and marginalized groups. So that's just a definition from, and a lot of that work, again, is coming up through the work of cities and public health departments and community institutions, community health centers. So the United States, I would characterize as stumbling our way toward a broader and more universal health system. We are the only, embarrassed to say, the only industrialized country, OECD country, that does not have universal health insurance. We pay more for our health insurance and get less for what we pay, in large part because of the extreme amount of profit grabbing and wealth extraction from the health sector. We pay, as a society, an average of $10,000 per year per person per cap, in healthcare expenses. So it's a huge amount of money is lost in our very, very efficient system. Nonetheless, we have made some progress, and this is my last scrambled slide, but we have made some progress over 50 years ago with the passage of Medicare and Medicaid. We actually do have a universal health insurance program for people who are over 65, so for seniors, and for certain people with disabilities. That is universal, and I'll talk a little bit at the end about the power of this notion of Medicare for all. Many people do get confused between Medicare and Medicaid. Medicare is our universal. Medicaid is a program that is federal and states working together, providing health insurance to low-income households. There was an attempt in 1993. President Bill Clinton campaigned on expanding access to health care. It would be unfair to call that universal or even single payer, but it was an attempt that was defeated politically. And so then, in the subsequent years, between, say, 1987 and 2012, the numbers of uninsured individuals in the United States rose steadily, as you can see here, from 31 million to 48 million. Over 15% of the population in 2012 did not have access to health care, and this does not even measure severely uninsured or underinsured households. And it was really here that the pressure began to build toward what people call Obamacare, what's legally called the Affordable Care Act. But it didn't just happen at the federal level. A number of states were incubators for what became the Affordable Care Act, including where I live in Massachusetts. I live in Boston. Our Republican governor, Mitt Romney, actually helped establish a much more broad and universal health effort. So people called it Romneycare. It was actually the model for Obamacare and some elements of it. So in 2012, we passed the Affordable Care Act, aka also known as Obamacare. It was passed in 2009, but finally began to become implemented. And its features are things you've heard of, but one was the fact that a large number of those uninsured households had pre-existing conditions. Even if they could get access to insurance, the fees would be exorbitant. So the Affordable Care Act essentially required the private insurance industry to insure anyone, regardless of a prior existing condition, and to have a rate structure that did not reflect that. That was a huge advancement. Young adults, half of the people in the United States are on insurance plans connected to their employment, on private insurance plans. Half, so it was a big deal that their children were mandated to be able to stay on those family plans until they're age 26. There's a mandate as part of the Affordable Care Act, which basically says everybody has to be insured. It's a way to get younger and more healthy people into the system, which was necessary for the whole economics and ecology of that effort to work. The biggest impact was the expansion of Medicaid in states, so more federal resources going to states to expand the Medicaid program. And this was subsidized. It was essentially paid for by several taxes, including a tax on medical equipment makers who got more business as a result of the Affordable Care Act, as well as a surcharge on high incomes. So there's, even in a short period of time, significant progress toward broadening insurance. So in 4 years, coverage expanded. 17 to 20 million people who were off the rolls were able to get on health care. That does not address the whole problem. I mean, 29 million people remain uninsured or underinsured, but we began to see some even early quick indicators that this was making a huge difference, that tens of thousands of lives were saved, as well as the quality of life for people dramatically increased. 31 states in the District of Columbia adopted the Affordable Care Act provisions of Medicare, to help states. But not all states did this, and this is an important point here. So here you see in blue the states that entered into a partnership to expand health care coverage. And you can see the old Confederacy states, largely with Republican, and it's hard to talk about health care outside the context of politics in the United States, but you can actually see the Plain states and the Southeast were the states that opted not to participate in Medicaid expansion. There's a typo on that slide, I think, but so here's a really concrete measure of health equity. Again, in a very short time, 2013 to 2016, the uninsured rate, just looking through the lens of the African-American experience, the uninsured rate for non-elderly African-American households individuals declined from almost 19% to less than 12%, just in a short period. And just so you understand, from a racial context, the white uninsured rate is 7.5% of the population. So the expansion of Medicaid to those key states was a key factor in broadening that coverage. And because African Americans make up 13.3% of the US population, but almost 19% of Medicaid recipients. So this whole move to repeal or cut Medicaid and repeal the ACA would have an immediate reversal on health equity and but really, since the beginning, since the first moment prior to its even passage in 2009, there's been organized opposition to expanding health care. Most of this is what I would characterize as ideological. Obamacare, the Affordable Care Act were characterized as a government takeover of health insurance. The House of Representatives have voted on 54 different occasions to either entirely repeal or repeal provisions of Obamacare. Again, this was sort of a free vote. They could pass this vote knowing that President Obama was president, that he would veto any effort. And I have to say, many of us who were concerned about health equity never thought that, we never thought there would be a reversal, that once this entitlement was sort of put in place, that it was just going to keep expanding, in part by virtue that it was changing people's lives. It was improving people's lives. And yet we had a whole political class that essentially campaigned on this idea of abolishing Obamacare. And again, it was a free vote. They never actually had to govern or think about how to replace Obamacare. So all of a sudden, something happened. And all of a sudden, like Voldemort, we won't use the name, but, he will, basically campaign on this popular within the Republican base, this idea of abolishing Obamacare. And what the House of Representatives did really just a month ago was they passed something called the American Health Care Act. People call it Trumpcare. It phases out the Affordable Care Act's expansion in those states that I showed you, caps federal payments. It eliminates the mandate that people have to have insurance, but it charges a very expensive surcharge if you go off of a plan. It essentially has a number of provisions that just shift responsibility onto the consumer, onto individuals, increasing their risks and costs. And, underscore here, it repeals all of the taxes that subsidized the access to health care. By the way, the House voted quickly, so quickly they did not wait for the nonpartisan Congressional Budget Office to actually score the cost of what and the impact of what they were about to do. With about 20% of the population agreeing with them, they voted almost entirely on a partisan line for this replacement, this repeal and replacement of Obamacare. The immediate impact, the report came out a couple weeks later. Immediately, 14 million households would lose coverage. And between now and 2026, an estimated 23 million people will lose health care if this plan goes into effect. Now, why is this happening? Why would they do this? It's just very important to understand that one of the drivers is a longtime Republican goal of massive tax cuts. And by repealing the Affordable Care Act, they save $1 trillion. That they eliminate $1 trillion of taxes, which they can then target to corporations and wealthy individuals. Almost the entire benefit of that tax cut goes to households with incomes over $200,000. So this is really the two-point plan here. And there was this discussion about, can we do tax reform even though health care has been stalled? And the Republicans understand they can't get the big tax agenda that they want until they push through this Affordable Care Act and the $1 trillion in tax cuts over the next 10 years. So what's going to happen? Scenario one is gridlock. That right now, the Senate, the U.S. Senate, is deciding what to do about health care and about what provisions of this health care bill they're going to take up. But one thing you should know, there's a number of these provisions that are incredibly popular. And so all of a sudden, Republicans who for years have voted against the Affordable Care Act are hearing from their constituents. Now, how is that possible? Well, here's an interesting sort of piece of the picture. Here's a map. The red states are the states that Donald Trump won in the last election. They're largely rural states, but from our political electoral college system, he was able to be victorious there. You can see the states that he did not win. But here's looking at side by side. There are 15 states that voted for Donald Trump but have agreed to expand Medicaid. Those are key states where, as Joni Mitchell said, people may not know what they've got till it's gone, but they're starting to understand the implications of this. So that is leading to some rethinking, certainly by senators in those states, but also by members of the House, that this may actually backfire. Part of the confusion is that a survey showed that a third, now this is an unfortunate statement about civics education in the United States, a third of the population thinks that there's a difference between Obamacare and the Affordable Care Act. So they support repealing Obamacare, but would like to keep the Affordable Care Act. This, I think, if we were to delve into the previous panel to think about maybe the othering, that people think Obamacare is for other people and the Affordable Care Act is for the people I know, something to that effect. But that's a startling thing. But as people wake up to the fact that they're the same thing, that the implications of repeal are draconian, and that they may lose their coverage. So even in the state where I grew up in Michigan, which overwhelmingly in the red voted for Donald Trump, if you look at the northern counties and the northern peninsula, overwhelmingly voted for Donald Trump, and that's where more than 1 in 10 households are on the Affordable Care Act. So it's really going to change the politics. The other scenario is they pass some horrible replacement that's inadequate, and we move back toward overcrowding and poor health outcomes. Either way, one trend is that there will be an opening up between states. Some states are actually moving more rapidly toward expanding access and addressing health equity. And this is, because of innovations and leadership in states and cities. Even in the last 2 weeks, the state of California, which as you maybe know has 35 million people, so it's a small country in and of itself, has passed, their Senate passed a universal single-payer health care bill, and it's moving on to the Senate. So we may actually see states continue to do state-level innovation. This will continue to build pressure for Medicaid for all, the expansion of Medicare for all. The most popular politician in the United States right now, one of the most trusted politicians, is Senator Bernie Sanders. He has made this a centerpiece of what he goes out and talks about. We have Medicare. It already universally covers a huge segment of the senior population. Let's just continue to expand that model. And he has a plan to pay for it. It's a $1.4 trillion plan that he would pay for with a number of progressive taxes. It would completely eliminate the role of the private insurance industry. Remember, we pay $3 trillion a year for a poor health system that doesn't cover us well. This system would be universal and would cost about half as much. Let me stop there, but I want to come back and invite you to check out inequality.org. We put a folder up. We put some folders up this morning. Some of you may have gotten it. We put some more up since most of them were taken. But in there, you'll find out more about where you can contribute, where you could write about some of these inequality issues that touch you. Thank you.
Thank you, Aaron, and thanks, Chuck. My name, as indicated, is Mvuyo Tom. I'm from Tigano. I'm going to tackle some aspects that were in the earlier slides of Chuck. The first 2 or 3 slides that talk about social determinants and health inequalities in relation to that, not more on the health care aspect or medical care. I want to take it before you need that medical care, rather than when you need it. I thought I should just first highlight one aspect or two about the man called Mandela and link it to the social determinants of health. Mandela was not just an inspirational leader, but he was also an inspired leader. And it's in his words, in this particular quotation, if you look at the words that he uses, there's men and women who fight the suppression of the human voice, who fight disease, illiteracy, ignorance, poverty, and hunger. So if you link all of those, you will have dealt with some of the aspects leading to social determinants of health. So the fight is against socioeconomic conditions which do not help towards the advancement of humanity. And that slide for me is very, very instructive, and it's also very instructive for organizations like Tikano and the fellows that we are trying to develop in the process, to not just be inspirational leaders, but be inspired leaders. They must be inspired by their commitment to ridding society of the social injustice. Just a glimpse on the challenges of inequity in South Africa and the profile of the country. It's a middle-income country. It's one of the countries where you see the three social, economic ills of poverty, unemployment, and inequality. You heard this morning from the student who was presenting here on labor issues in South Africa, repeal, about the unemployment rate of about 28% in the country. And if you take the various groupings and geographic areas in South Africa, you'll find some areas that are at 40% of unemployment. So if you take the average in South Africa, you will not have sight of what exactly is happening there. South Africa is the most unequal society in the globe. By all measures that have been made, we have been classified as the most unequal society. Again, we do go back to that crime against humanity and look at what was there before and what impact it had on South Africans in general, apartheid system. If you look at, again, infant mortality, by 1994, it was about 130 in every 1,000 births in South Africa amongst black people, and 13 per 1,000 live births amongst whites. And again, if you take the average of infant mortality in South Africa, you lose that picture. So, you look at stunting. Again, today we talk of 1:4 of children being stunted in South Africa. But that's the average. If you look at what is happening amongst black children, 28.4% and 1.1% amongst whites. So in general, never study South Africa as just one single population. And I'm not trying to do what John talked about earlier this morning, othering. I'm othering in the positive sense that we have to address the inequities, whether they are in racial terms, or gender terms, or class terms, or disability or ability terms. You have to address that. I've shown you that in 1994, the infant mortality amongst blacks was about 132. At the height of apartheid, around 1970, that's what it was. But if you take less than 1 children, you had the 135. Look at what it was for whites, Asians, and colors. So these two population groups in South Africa almost share the same picture if you look at mortality rates in all age groups, as you can see here. That picture has not changed significantly in 2017. Inequity is very pervasive. It affects every sector of society, every aspect that is related to social determinants of health is affected by inequity in South Africa. Hence, in the globe, there's a call for health in all policies. Every policy that you have, whether it's a housing policy, whether it's a sporting policy, whether it's a built environment policy, you need to make sure that you can have something that deals with health in that. And that can address some of the issues that are bothering us, not only in South Africa, but in the third world, about the determinants of health. And I thought we should here have this definition about health equity, as that shared responsibility and requires the engagement of all sectors of government, of all segments of society, and of all members of the international community in an all for equity and health for all global action. That's the WHO's call for everybody. You will recall that in 1978, there was that call, health for all by 2000, and little of that was achieved. We went on to the Millennium Development Goals. Not much was achieved in some countries, and we're now in Sustainable Development Goals, and hopefully 2030 will be able to address some of the things that we have outlined there. I'm not going to spend a lot of time in this, what is what, so that we are all on par when we look at the inequities. Health inequalities, FARA and the WHO coincide in that definition, and Tigano has defined health equity for our own purposes as fairness in the distribution of health resources and outcomes. So it's not just what is happening in the hospitals, in the clinics, anywhere else where healthcare is provided, but it's also what is happening in terms of the preventative measures, the promotive measures that are required in order to ensure that all your people gain from positive action in social determinants. And just the social determinants, we've listed some of them. Issues like education are there, and we had this morning talk about some of the European countries where education seems not to have an impact in terms of social mobility. But if you go to any country in the South, the global South that is, you will find that education is still one of the most important social determinants for health. In fact, the longer time you spend in education, the more chances of having a healthier status than those who have spent less time. And the longer time is a progressive longer time, not that you are repeating years, of course. Then we deal with the causes of causes. Why should a child in Mthatha, in a village, present with a disfigured face caused by tuberculosis of the skin? What was wrong with that child? Is it just the child was predisposed to tuberculosis? Is it that the bacteria is more common in their area or not? More factors affect that. Barriers to health may arise from food and economic equity issues like poverty, employment, food security, housing stability. May arise from social and community context, social cohesion, civic participation, discrimination, incarceration. May arise from health and healthcare, and I think Chuck has explained that to all of you. I'll touch briefly on that at the end. Education, still have it there. Language and literacy, early childhood education and development, high school education, etc. Neighborhood and built environment. All of these are very important in terms of ensuring the barriers to a healthier nation are removed. These are related to the social determinants of health. Now, I'll give you a bit of evidence from our Tigano work in terms of the inequities that manifest themselves in South Africa. And these disparities are between segments of society in terms of health outcomes, education, employment, earnings, housing, and access to basic education. And if you look at this picture, which I'm not going to go through in detail, we have talked about poverty. Poverty in South Africa is affecting the various population groups unequally. Whites, there is the percentage, 0.91%. Indians, 5.9%. Colors, 29%, and black being African. I know that some of you will know black as including all those three categories, but for purposes of this presentation, we have separated them. So whether you go to housing services, whether you go to food security, the averages may mislead you if you don't go deeper and break that down to this. Education, similarly. Education in terms of access to education and in terms of the outcomes. If you go to the success rates in South Africa, whether it's in matric or high school or at university, the success rates will show you the differences. Success rates for People who completed secondary school in South Africa, 64% whites, 63% Indians, 37% amongst colors, and 29% amongst Africans. So all the social determinants of health show the inequity that you have. And as I said, I'm not going to go through all of them. This picture I took in an informal formal settlement. The existence of informal settlement within a formal settlement in Dungan Village in East London in February. There's an early childhood development center next to this area. This is supposed to be a communal water service point. And if I pointed that to you, you would know what is there. The water that runs from here runs through pipes, a big pipe that goes through there. This is supposed to be sealed. But the children who are in that particular center next to this is a sewage point for them. They use buckets in the center, and the buckets are emptied here, and the water from here, when it runs, will take that to the sewage pipes. Now, we have said early childhood development is a social determinant of health. And if children are exposed to that in their early stages and to the quality of the service, you can imagine if the housing is like that, what does the center look like? And you can imagine if the service is like that, the teachers who come from there who are supposed to assist these children, what qualifications they have. So the outcomes will be determined by all these environmental changes that are there. I just thought I should show you that. Now, more evidence of this, and I'll go quickly. If you take the 10 top causes of mortality in South Africa, these are communicable diseases and non-communicable diseases. Amongst African, the top 10 contains five of these. Amongst the colored population, only 2 communicable diseases, and here, 1, and 9 are non-communicable diseases. And almost all of that, all of this is preventable. So the disparities happen not only with the services, but also with the outcome. And this shows some of the issues I'm talking about. HIV and AIDS, around 2000, accounted for about 28% of the burden of disease in South Africa. And in the main, you've got infections, and you've got unintentional injuries and intentional injuries. Before, respiratory diseases are also related to infection and things like asthma. So non-communicable diseases in the main are fewer in the average in South Africa than communicable diseases. And therefore, when you come to recommendations, and I'm going to move faster, I've got 2 minutes, recommendations and opportunities, most causes of inequitable health outcomes are preventable, and you should prevent that. And in these slides, we need to have society and government working together to address the ills of our society. And towards the end, if you look at this particular slide, opportunities exist in South Africa. The National Development Plan, the National Health Insurance System, which will cover some of the issues that Chuck raised, and all of those can assist greatly in this. Organizations like Tikano, having learned from the TAC, the Section 27 organizations, and the equal education campaigns, we can be able to develop a movement that can assist in addressing these matters as speedily as possible. Lessons from the past, I thought I should show this, that Britain, at some point, did have some of these illnesses that we're talking about. Conditions attributable to microorganisms, which are communicable. If you look at the 19th century, they were responsible for that amount of burden of disease, waterborne, etc. But look at what was the case in 1971. And most of this is not due to drugs or any other thing, but improvement of the conditions under which people live, work, and grow to old age. So we can remove most of the burden of disease in South countries if we deal with the determinants of health. Thank you very much.
So hi everyone, my name's Anne Rathbone and I'm the Senior Training and Development Consultancy Manager at Boing Boing, and I have the lead on co-produced research within Boing Boing, and I'm also a final year PhD student part-time at the University of Brighton.
Okay, can everyone hear that? Yeah. My name's Simon Duncan. I'm a training, participation and project worker for Boing Boing. That's a mouthful. Also, just to mention quickly in relation to the previous panel, not a disabled superhero. So just to make that clear. Okay.
So cut him some slack.
Absolutely, it's late.
Okay, so just a brief overview of our presentation. We want to talk to you about the University of Brighton Boing Boing partnership. So what does that mean? And about our inequalities approach to resilience, why we've decided to take an inequalities approach to resilience, and some practical examples of how we do that. And Simon's going to, as I said, Simon's going to talk about what that looks like in practice. So Boing Boing is a community interest company, and it was established in 2005 by Professor Angie Hart, who is a professor working on resilience, particularly at that time in relation to children with complex needs. But we've since broadened out our research agenda to young people with complex needs and also adults with learning disabilities and parents of children with complex needs. And she set up Boing Boing in partnership with Kim Orman, who at the time was director of Amaze, which is a support and advocacy project for parents of children with disabilities in Brighton. And Boing Boing was set up as a vehicle for co-produced resilience research and effective knowledge exchange, and to putting the research evidence base around resilience into practice for both practitioners and for parents of children with complex needs. So the aim of Boing Boing is to model, promote and deliver co-produced resilience research and practice, and we do that through effective knowledge exchange and with an explicit inequalities approach. All our activities based on the resilient therapy approach and the resilience framework. There's a book around this, it's on the reference list at the end, but I'll just show you quickly. This is the resilience framework, which was put together by Angie Hart with Derek Blinko, who's a psychiatrist, and Helen Thomas, who's a social worker. So it's one of our first co-produced outputs. And at the time, it was just a way of categorizing the evidence, but actually we found over the years that both parents and practitioners really like its accessibility, so it's had a much longer life than we ever imagined. I won't go on about it, but you can see from this how many social determinants of ill health, mental and physical health are associated in this. So there's just an illustration of really how long we've been working within a societal structural framework around resilience. So although resilience study, I'm not going to talk about resilience today, but resilience study has effectively evolved since the 1960s and has become increasingly taken an ecological approach. But despite that, there are quite a few criticisms of the study of resilience per se, and those voices are becoming more vocal, and how the concept of resilience is applied to social policy. I'll just show you some quotes. So Friedley is one of the most vocal critics. One of the things he says, a focus on resilience cannot adequately explain inequalities and well-being, and may serve to disguise or distract from the analysis of social structures that result in and maintain inequalities in power, wealth and privilege. Another one, the individualised notion of resilience obscures historical and more recent structural inequalities that are fundamental barriers to the well-being of the poor, and blames and penalises them for what are deemed to be their failings, deceits and unhealthy dependencies. So very strong echoes of the last session you can see. And Taylor, Matthews, Atfield and Parry say resilience is putting a sticking plaster over the wound that's caused by macro structural inequalities in power and resources. So what these critics are saying, essentially, what they're complaining about is that resilience research, firstly, has been hijacked by a neoliberal agenda, and that as austerity increases, calls in social policy for communities and individuals to be helped to be more resilient also increase. And secondly, that resilience research is by default colluding with that agenda. So we decided to respond to that, which was kind of easy because we were sort of doing that already, but we decided to take a much more explicit approach to social inequalities. So our boing approach to resilience now is an overarching critical approach that acknowledges the importance of individual resilience, but it doesn't individualize resilience. So it doesn't, we work beyond focusing on individual attributes and characteristics, whether they're innate or learned, and we focus much more on the rest of the system and how we can understand that, address that, and tackle that. And it's led to us thinking about and writing about resilience in a different way. So the way we talk about resilience now is that really resilience is overcoming adversity whilst also potentially altering or even dramatically transforming aspects of that diverse adversity. Now, obviously, that's contextual. We can't change the world with every research project, but it's a fundamental value. And in boing language, which is always a bit more down to earth, we call it beating the odds whilst also changing the odds. So how we take an inequalities approach is basically 4 ways. We target our research towards understanding issues for people whose needs are currently underrepresented. So there are gaps in the resilience research, for example, around young people with learning disabilities, so we tend to take quite a strong focus on that. We always use co-productive methods, and we've got a very strong value base around amplifying the voice of lived experience in both our research and our knowledge exchange activities. We try to focus on social transformation across ecosystems within our research and as an output of our research, and by embracing sustainability. And what that means is that all the young people, as an example, that we do research with are never thought of as subjects of our research. They're all co-researchers, and we try to develop them according to their interests, needs and abilities into growing positions within Boing, whether that's as volunteers or paid staff. And we have actually 5 young people on the payroll who started off being involved in different research projects, and they all have complex needs of some kind or another. So we use a democratic learning community approach for that, and I don't know if people would know about it, but we tend to use Etienne Wenger's community to practice model. So these are our 3 values, our main values in the middle. You can see addressing inequalities, research and co-production. We don't do anything, however much money we're offered, unless it's in the middle of the overlap between those 3. And these are some of the core people that are involved in Boing. And I wanted to show you this because it gives an indication of the multiple identities that are involved in Boing and how the synergy that's related to that is so important. So you can see that this is not the total number of co-researchers that we have. So these are young people that have been involved in our project, maybe children, not so much. But certainly parents of children with complex needs. They all have lived experience and they're all co-researchers. So we invite them to develop their skills as co-researchers. We train them to be peer researchers and so on. Simon's going to talk a bit more about that. We have 4 professors who also have lived experience, either as individuals with mental health history of mental health problems with lived experiences being carers of children or adults with complex needs. There's nobody in that diagram that has a single identity, and the synergy between those identities is core to how we work. So I won't go through these. Just some examples of our recent work. We work on national and international Research Council funded projects. Simon will talk to you about some of those. And we also work directly on a £60 million lottery-funded strategic programme, which is about promoting systems change within children and young people's mental health services. That's Head Start. We'll tell you a bit about that.
Okay, so diving right in. Now that Anne's introduced you to Boing Boing and the University of Brighton's inequalities approach, I'm going to run you through some examples of how this worked in practice, metaphorically, of course. So, moving forward, earlier this year, in partnership with the University of Pretoria, I was invited to be trained as a co-researcher as part of a team of young people. So that included 16 South Africans and 2 Brits, including myself. So as we were trained in co-research in a South African perspective in relation to drought, looking at how young people were resilient and able to foster resilience when their lives are affected by drought. So there I am, actively going into Leandra, the community where we were, and helping to facilitate those activities. But through that training of facilitating those activities, the young people who were involved not only were able to start a conversation around the assets and resources that they utilize to become more resilient in the face of harrowing drought, but also were empowered with the skills to become co-researchers and social activists within their communities. As we speak now, they're actively working on the second phase of the project, and I'll return to South Africa next week, where they are actively talking to elders within their communities, looking at historical droughts and the impacts that these had on their communities. So moving forward, you've got my mug again. Pleasure. Yeah. So what we find is that when you ask a young person to talk about resilience, they tend to clam up. Now, typically, this is because the experience that young people have when they're asked to talk about resilience is a counsellor sat across a table going, tell me about all your problems. Now, isn't that a touch interrogative? So in response, we co-produce different resilience tools with young people to enable conversations about resilience that are friendly, fun, and non-threatening. As you can see under there pictured, you've got the Sun and Clouds game. Now, this was co-produced by young people with learning difficulties from the Arts Connect group that Anne works with quite heavily. Keep that in your head, that name, because it will return again. Now, this game in particular enables players to talk about different situations and how to be resilient in those difficult situations. So, for example, dealing with prejudice or having people not understand your needs. It's also a very fun game. 1 minute you could be talking about how to deal with prejudice in the moment, and the next you could be doing a Mexican wave. So, it's very varied. Okay, so moving across, there's a second resilience tool there, the Resilience Roadmap, which has been co-produced with the young people of Head Start Blackpool. Now, Anne has mentioned the £60 lottery bid, the Head Start bid, which is actively an initiative across Blackpool and several other regions, which aims to improve mental health outcomes for 10 to 16-year-olds in the region by initiating systems change. Now, my role in Blackpool is twofold. Firstly, I use my lived experience as a wheelchair user, someone who's had mental health problems and suffered income inequality in the past, to give context to the framework to practitioners, parents, and young people. But secondly, and most importantly, I work to initiate systems change by altering the way that mental health issues are perceived and addressed. Now, the way that works is I try and move the perception from an individualized sense of, okay, this is the young person's problem, and we're going to fix this young person, this specific young person, to examining a more system-wide change. So looking at the community outside, the school, friends networks, etc., and pushing forward, saying, okay, how can we make that system more equitable for all? Yeah, I'll be quick. So in part of our work, what we do is a lot of patient public involvement to influence research direction. So I was involved in a panel to select a mental health research fellow to actually ensure that the person would listen to people with lived experience. If we quickly move to the left here, because we're running low on time, we're looking at, in the second phase of drought, the young people, the young co-researchers, are going to create a film which will tell people and policymakers about what systems change would enable them to be more resilient to drought. And this will directly be shown to them. Third picture, I'm sure all of us know about the Southern Rail strikes and how awful this was, but this had a particular impact for the Arts Connect group. Because of the timetable chaos, their trains were overcrowded and they couldn't access any social groups. Rather than suffering in silence, in an act of social activism, they have arranged a meeting with the Disability Liaison Officer for Southern Rail to try and arrange a mutualistic solution to this. And finally, we note that in practice, in co-production, when it happens, people tend to co-produce with so-called easier young people who don't have disabilities. But instead, the Arts Connect group, in response to this, have created a film explaining why co-production with people with learning difficulties is necessary and achievable. And I'll pass over to Anna.
Okay, thanks. I'll just finish off. And just to say that all those examples are examples of young people's supported social activism, but within academic research projects. So I think it's quite important to say that. So just to conclude, I hope that we've managed to give you a flavour of Boing Boing. It's not a standalone community interest company. It's very much melded together with the University of Brighton activity. It's a great privilege to work with the University of Brighton. It's very much part of their strategic aim that to develop really effective community and university partnerships. But it doesn't mean that it's the only place it can be done. So we would just like you, hopefully we've inspired you to at least think about, as academics, whether you can increase the impact of your research and work on equalities by actually working with third sector organisation in a long-term sustainable manner to actually be able to implement real impact and sustainable change. Thank you.
Oh, sure.
We have time for a couple of questions. I'll take two to start with, and we'll see how the time is going. So, would anyone like to go first for us? Yes, please. Blue shirt, and another one while the mic is getting.
Hi there. I'm Chris Brooks from the UK Health Forum. Thank you for the presentations today. It's actually Dr. Mvoyo Tom. The question about health and all policies. We talked about needing to use a health and all policies approach. In practice, what might that mean to help to address health inequality? I buy what you're saying, but I want to know about some of the practicality that might lie behind.
There was a question just a few rows back.
Hi, thank you. I'm Alex Bax. I'm Chief Executive of a charity called Pathway. We support the NHS to improve health services for homeless people. I guess a question for Chuck. I've been fascinated in the history of the Affordable Care Act and Obamacare. One of our observations, I think, in the UK is that healthcare itself is only responsible, or any health equities are only mediated by healthcare, perhaps 20 to 30%. Most health inequalities occur upstream or elsewhere in society, as our colleague from South Africa showed. What else is happening, perhaps in America, to look upstream? Healthcare is necessary but not sufficient.
Yeah, please, yeah.
Okay, thank you. I'll answer the question on the practical issues related to health in all policies. Firstly, in South Africa, we had, at the turn of the century, around 1994, when we got our freedom, what was called the Reconstruction and Development Program. That Reconstruction and Development Program had, in every policy that was included in it, some integration. It didn't call it health in all policy, but if you looked at what was discussed under sanitation, water and sanitation, you knew that the targets would assist in achieving the health outcomes that are required for the country. If you looked at nutrition, in fact, Madiba just introduced nutrition quickly and said, deal with nutrition and all departments must deal with this. So all you need is to have an integrated developmental approach. And the current situation, that's why I raise it as an opportunity, is within the National Development Plan. The National Development Plan, and it's available in the website of government. If you can go through it, you'll see right from early childhood development, education, infrastructure, and everything that is related to the development of the people of South Africa is touching on aspects that will improve the health outcomes that I was talking about here. So in a practical sense, I'm saying let's do a social mobilization of people to ensure that government implements the policies that are included in those documents. Because in many respects, implementation of policy in South Africa has been sort of a mirage. It's not achieved by many departments. You find what is called very, very good policies, but the implementation is not done. 2030 is around the corner. That document was approved in 2011, and we're now in 2017, 6 years gone, and very little has happened. Even with the NHI, pilot sites have been defined to ensure that there's access to quality health services, not just a clinic there, a hospital there, but there must be quality services. The NHI fulfills some of the access and equity issues that we talked about early in the 90s when we talked about a change South Africa. It's a matter of implementing what is contained there. And the integration must not just be in government terms. It must be all sectors, the public sector, the private sector, non-governmental organizations, and civil society in a broad sense, talking one language. Thanks.
On terms of Alex's question, I think you're absolutely right. Healthcare is just one dimension. What about the upstream forces? And I think the best practices are in these community health centers. They tend to be in urban areas, less in rural areas, that have a health equity framework to what they do, and therefore are looking at housing, nutrition, recreation, stress reduction, just a whole, and have try to patch together a set of holistic responses there. Getting healthy food into schools, nutrition access, putting people in health centers as people come in to talk to them about their housing situation. Are they in a bad housing situation that doesn't have heat, doesn't have access to water? Trying to intervene in those sort of determinants of health. So, and a lot of, doctors who are working in these community health centers become some of the best advocates for the broader health equity movement and approaches.
Before we thank our speakers, there is in your packs a feedback form, which I know the organisers would be very glad to receive. So if you do have some time, fill that out, hand it back up to the registration desk. I'd just like also to then, while we give our thanks to our speakers, to invite George Alagaya and John Hills up to the stage to present the Action for Equity Award. But if you could just join me again by thanking them. Thank you so much. Thank you. Thank you.
Thank you all very much. It's a great pleasure to, I should say before we start this, that all the slides you've seen during the day will be up on our website, possibly not immediately, but soon. And then sometime next week, towards the end of next week, there will be video available of the whole day's proceedings, including this evening. It's a huge pleasure to introduce George Alagiah. I've been grateful to George on two particular occasions. The first was when I came home one day 30 years ago to discover that everything from my house, including all the furniture, had been stolen. And George and his wife kindly took me in. This was in Harare 30 years ago. And the second was when George very kindly agreed to be the chair of the jury for the first award of the Action for Equity Award. George, those of you who get home in time will know, is the anchor of the BBC News at 6 o'clock. He's very kindly taken today off in order to present the award, but also has been the chair of the jury which decided on which of the many organisations that were presented to us would receive the award. George, thank you very much.
Thank you very much, John. I'd forgotten about that, actually, 30 years ago. My, time flies. But when the news broke overnight of what's happening in North Kensington, I really did think I wasn't going to be able to make it here. But it turns out, amazingly, that the BBC can cope without me. So you've got me instead. One of the things we do at the BBC, it's something of a religion, really, is balance. And when it comes to something like inequality, and we have this thing called reality check, you've probably seen it on the BBC website, it turns out that how you define inequality, how you say whether it exists or not, really kind of depends on who you ask and how you calculate it. And as I've heard today in some of the talks, there isn't even agreement about what it means necessarily. So in a way, in the Action for Equity Award, what we did was kind of sidestep that argument. We're going to leave it to people like you. We've left it to people like you. And what we did was to go out and speak to the people, if you like, on the front line, those people who don't really need to define it, who don't need to calculate it, who don't need to measure it, because it's just hitting them in the face every day of their work. And it was quite humbling, really, to go through not just the shortlist that we've ended up, but all the others that put in for the award. And just on a personal note, in journalism, we spend an awful lot of time talking about problems, pointing to failures. And for me, along with the judging panel, it was an absolute privilege to be a small part in being part of a solution, because the organizations you're about to hear about, no question about it, they are part of the solution. I didn't do it on my own, by the way, judging these various entries. And I'd just like to thank now Omar Khan from the Runnymede Trust, Baroness Glynis Thornton, Anne Power from the LSE itself, Steve Reed from the University of Cape Town, and Lee Elliott Major, who helped in coming up with the shortlist. Let me just give you a little idea of what this award is about. You may know it already, but it aims to celebrate and support the work of charities in challenging inequalities. And the award is connected to the Atlantic Fellows Program for Social and Economic Equity based here at the International Inequalities Institute. The fellows will be able to interact with the winner of this award to develop their understanding of how to challenge inequality. So it's a kind of two-way street. Now, I know people in my position are always saying this, but all the applicants were actually very, very good. And if I'd known how hard it was going to be to come up with a shortlist, I would have said no to John. Anyway, we ended up with 3 finalists, and we've got 3 short films that I think will give you an idea of the kind of work they do. And the films are about hope into action, participation and the practice of rights, and the Shannon Trust. And I think we'll be able to see those short films in that order.
So 7 years ago when we started, Peterborough had the highest rough sleep count of any city or town outside of London.
And that's really one of the things that birthed this. If you're homeless, you spend your entire day fighting for survival. You need to get food, you need to literally make sure no one steals from you as you sleep each night. We say there are 40,000 churches in this country, and our view is every one of them has a financial capital and social capital, and most of it is latent, to be able to buy and run a house for the homeless. This is the Support Centre of Home Interaction, which is based in Peterborough. This is where we began. We're now in 10 cities across the country, and we support those cities from here. Then we have another 6 cities which are franchised cities, so we partners there, either churches or other individuals that are replicating our model in their cities. We train them up on how to do it, and then we give them advice and guidance on an ongoing daily, weekly basis, and then we monitor what they're doing to ensure it's done in a quality way. We believe if someone has a secure, safe home and positive relationships around them, they're more likely to find the motivation to change. And then our statistics will back that up, because over 87% of our ex-offenders, for example, have not gone on to commit a crime. So we're going to one of our first ever houses. It was bought by an ex-copper who wanted to do something for ex-offenders, and as he retired from the police force, he was given a lump sum. He wondered what to do with it. He's invested it in a house, he's bought a house, and we're going to meet a guy called Jimmy, who's a lovely guy, who is an ex-offender. I hate that term, but he has been in prison, and he's now doing really, really well. So this is an estate we bought a house on. It's 5 minutes from here to the local church. People from the church literally live on this estate. And the criteria I always look for when we're buying houses, would I be happy for my daughter to live in this? If I would be happy, then generally we go for the house. So here we are, this is the house just here, and we're just looking to see if Jimmy's in.
Oh, hi.
Hey Jimmy, how you doing? Good to see you. Yeah, you alright?
Yeah.
Yeah, lovely, thanks, yeah, cheers.
Been here since October. It's a nice house, nice, clean, tidy house in a good area, and yeah, I'm enjoying it. My situation before was homeless at first, and was living kind of rough. Got told about Open to Action and turned up there, and basically they gave me this opportunity to have this place, you know, and build a foundation from there. My biggest motivation is obviously that I want to better myself for myself, but not just for myself, for my friends and my family. Also, I have a daughter. She's, you know, a big drive for me to, you know, succeed in life. I don't want to be like grown up and my daughter looks at me and she goes, oh, he's got benefits, you know. But you have to sometimes like use your resources around you to get to certain places you need to get to in life.
So if someone doesn't have a home, there is a tragedy of inequality that's occurred. And at the same time as him not having a home, you'll have 100 people in church that live in a home and have loads of money stored up in bank accounts that we can use to make it more equitable. We see a point where it's normal for churches to run a house for the homeless. At the moment, it isn't normal for a church, it's quite exceptional. Why can't it become normal? If it becomes normal, you unleash this huge wave of latent social and financial capital into the lives of those that need it most.
People a year in prison to start learning to read with turning pages. It's fundamentally a peer-mentored reading scheme which addresses some of the really important inequalities that people face in life, and particularly people in prison. In England alone, 16% of people, 5.1 million adults, struggle with reading. When you step inside the gates of a prison, this increases to a staggering 50% of prisoners. You can't read letters from home. So many people talk about not being able to stay in touch with their family. You can't do things like fill out your menu sheets to choose what you're going to eat. So many people end up eating the same thing day in, day out, and not having a choice. Javid is a former mentor. He got involved with the reading plan. He was recommended it by prison staff who thought that he would be able to use some of his skills to be able to support other people in the prison.
People don't expect to have opportunities like this just inside prison. They just think it's just a place where you get locked up 20 hours a day and you don't have no opportunities or no chances for yourself. It gives you that boost of confidence to think that you can do it. It's just not that hard. It helps let's create a bond where we actually are working on something that's really good. We're sort of creating a better future for both of us. You've got to get to know them first. You've got to not become like a teacher, but like as a best friend in a really short space of time.
I was what's now termed a career criminal, and altogether I spent about 16 years in jail. It's difficult enough as it is for a former prisoner to get a job. It's quite difficult. You imagine how much more difficult it is if you can't read or write. I personally know people who've learned to read in prison and write in prison through Shannon, and they found employment for the first time in their lives. By giving a person who could not read or write, the ability to read and write, it's absolutely a life-changing experience. It's almost like being blind and then you can see.
Turning Pages has been externally evaluated by Birmingham City University, which says A, that it helps people to read, and B, that it develops both our learners and mentors in many other ways, building confidence, self-esteem, communication skills, and giving them some control of their lives in an otherwise very constrained environment.
I can't explain how much good they are doing for a lot of people. It unlocks people's imagination, which is so powerful to young people. It really helps them to think and believe in themselves. And that's what people, and the volunteers and all the workers at Shannon Trust do. They help you believe in yourself and unlock your potential. And they really are changing lives and inspiring lives every single day inside prison.
Of the many thousands of people who've learned to read in prison through the Shannon Trust, I'm certain that many of them, it's been a turning point in their life, and it's changed their life immeasurably.
Our organisation was set up in 2006, so essentially what we do is to educate people as to their rights, but also to develop campaigns and techniques for them to effectively create change. The first campaign that we got involved in was around poor accommodation, high-rises that had been built in the 50s that were still standing. People began telling their stories, and through their stories we identified the issues that were plagued by damp, mould, cold, pigeon waste on landings where children were playing and clothes were being cleaned, and sewage ingress coming up through sinks, all of those issues. What we done then was to wrap those issues in human rights, and what our groups do, they go into their communities, they speak to their neighbours, they speak to their families, they speak to their friends, they gather the evidence that a human rights failing is indeed occurring, and then they set down a marker for the progressive realisation of their rights to make meaningful change for themselves on the ground.
We're at West Belfast, Lower Shankill, one of the most deprived areas in Northern Ireland, because there is little or no employment within this community. This community used to be full of paramilitary murals. This mural is part of re-imaging. It is what we stand for with regards to human rights, because if you look, it's about mental health, it's about education, it's about jobs, it's about participating with regards to what is happening in your community. This was North Belfast unemployment office. Government figures stated that they were going to create 5,000 jobs over a 4-year period, when in fact there were only 25,000 people unemployed. We thought that there was a campaign to be had with regards to no jobs and lack of social security benefits being paid to certain individuals. We came down here for about 6 months on a weekly basis and had workshops. It was obvious that people were being sent for jobs that weren't there. We got them to engage with regards to filling in surveys, informing people of their human rights, how they were being abused, and what we were trying to do to try and readdress that. We went to Belfast City Council. We've got cross-party support to pass the motion which was passed, which secured jobs for long-term unemployed people.
So in our view, change only happens when those affected by inequalities are at the table and meaningfully involved in every facet of decision making regarding budgets, regarding allocation of funds, regarding policy, regarding plans, all of that, but they're involved in every aspect of it. That's when change is meaningful and real and achieved.
So you can see what I mean. You know, any amount of discussions about inequality and what it means and what to do about it becomes absolutely meaningless if you don't have people like that who are just willing to go out and do the business. So that was our short list. Let me give you just very briefly a précis, if you like, of why the judging panel ended up with these three. And I'll take it in the order in which those videos were run. So with Hope into Action, our feeling was that addressing homelessness was one of the key factors in dealing with inequality. And what we particularly liked with Hope into Action was the way in which they were using private money, private funding, and channeling it towards a public good. We just thought there was quite a nice mirror image going on there. As for the Shannon Trust, I guess we were impressed with their kind of unique peer-to-peer model, that inside the prison you had some people who were learners and some people who were teachers, and both of them actually gained from it. By the way, in this process, you know, the judging panel went out to visit these teams. We had lots of discussions, so we know a lot more about these organizations than we're able to tell you here at the moment. And we thought that kind of model, the peer-to-peer model, is something that could be replicated in other places. And finally, with participation in the practice of rights, I think what impressed us was the way in which PPR have given the people they work with a sense of empowerment, of agency. And going back to what I was saying earlier, that it, you know, it's not something you can measure, you can't count it, but you probably heard there, people have a sense of empowerment, and that's hugely important to give the people themselves this sense that they are their own masters, they can do something about it. So that was the shortlist. That was why we got to a shortlist. It is now my great pleasure to present the Action for Equity Award 2017 to the Shannon Trust. This is Angela Cairns, who's CEO of the Trust, and she's going to just say a few words. Well done.
Thank you. Thank you ever so much. I'm absolutely thrilled to be able to receive this award on behalf of Shannon Trust and everyone who's involved in it, particularly in the light of the fantastic shortlist. Just seeing these films now, the second time I've seen them, but very moved as well. We have a fantastic staff team, volunteers, and counterparts in prison who help us do this. But this award today is for, I'm sorry, a little bit emotional, for our learners and mentors. They do all of the hard work. They are the people who, on a day-to-day basis, are changing lives of others and their own lives at the same time. So thank you on behalf of all of those people who will be so proud when they hear about this.
And I'm sure people can go to the website to find out a little bit more of the award, the interaction that's going to happen. You know, it's not a sort of one-time thing, you know, wham, bam, thank you, ma'am. There's going to be involvement with the fellows, and indeed there's some money too. So let me now ask for Chris Exley, who is the President and CEO of Atlantic Philanthropies, to come and tell us a little bit about why they backed all of this.
Thank you, George, and thanks everybody here. It's a real privilege for me to be here, and I'm grateful to be with a community of such diverse and competent people who are dedicated to addressing inequality in a global context. These are not simple challenges. They are not short-term challenges, and they will take sustained and passionate effort of the sort that I sense exists in this room, and we are privileged at Atlantic Philanthropies to be able to support part of what you do. The value of understanding what causes inequalities before tackling problems, the ability to understand the root causes of the challenges that we face is essential, and it can't be overstated. And the importance of knowing that before trying to solve those problems is evident in some of the organizations whose films we have just witnessed. The Shannon Trust understands the daunting barriers that face people who leave prison without the ability to read, and how being illiterate increases the likelihood that former inmates will end up in prison again. So congratulations to the Trust. Your work is really meaningful and effective. The other nominees for the Action for Equity Award, Hope into Action and Participation in Practice of Rights, among whom are organizations that Atlantic has supported at other times, also stand as proof that if you want to make an impact on addressing problems stemming from inequality, take aim at the root issues. One of the reasons we're so motivated to support LSE and the work done at the International Inequalities Institute is that dedication to looking at the fundamental issues behind inequalities. But I'm also grateful to John Hills and Mike Savage especially for embracing the continuum from evidence-based research into turning that into action. And we hope that this Equity Award, the Action for Equity Award, is a reflection of the realization that all the work that this academic community does is really in service of ultimately having impact in the communities that we care about and to creating fairer and more equitable societies. Nelson Mandela once said, "Poverty is not an accident. Like slavery and apartheid, it is man-made, and it can be removed by the actions of human beings." The late, great Tony Atkinson, I think, has a quote that you've seen in the course of our breaks that similarly notes that we can do something about this. We're not condemned to live in unfair and unequal societies. We have the ability to understand them, understand the root causes, to address them, and to do so effectively. And I think the nominees for the award are an indication of how action can have real impact in communities and sustained and lasting impact. Throughout much of my career, I've seen the power of human beings to make a difference. Among the individuals I've been privileged to be associated with is Chuck Feeney, whose generosity helped fuel the action of leaders and change makers in many areas of the world in which Atlantic Philanthropies have worked. For those of you who are not familiar with Chuck's story, let me summarize it very quickly. 35 years ago, Chuck decided to devote virtually all his wealth to the service of humanity, and it led him to establish the foundation we refer to as the Atlantic Philanthropies. He was one of the co-founders of Duty Free Shops, a global duty-free retailer, and that was the source of his initial fortune. We like to think that it was a form of a private progressive tax, taking luxury goods and turning them into money for good. Chuck is a believer in giving while living, the idea that people of means should use their money to better the world during their lifetime. And over the course of our history, Atlantic Philanthropies has invested $8 billion, principally in 8 countries, to promising programs and people. And we made these investments in places where we saw the chance to support champions who were effective, such as many of the people in this room promised to be and are actually doing things to promote greater opportunity and fairness in societies. One of Chuck's quotes is, "In the end of the day, it's all about people." And in our final commitment, we are a limited life foundation, and we have made our final commitments at the end of last year. We've chosen to invest in a group of fellowships, and I think we have a slide somewhere. I don't know which buttons to press. Continue while we wait for the slide. I know we're already behind time. The idea was that really the effective agents of change are people such as yourself and the organizations that you are investing yourselves with in. And growing out of the work that Atlantic had done historically and in the regions in which we've engaged, We've initiated 6 fellowship programs that are listed on the screen that reflect some of the themes that Atlantic has historically addressed, and focusing on some of the root causes of unfairness and inequality in those regions. You'll see that the themes that we've chosen to tackle are, as I said, complex, nuanced. They won't be addressed in the short term, and so the philosophy is that we want to invest in people such as yourselves and your colleagues that in the long term will continue to make a difference and amplify and multiply the kinds of efforts that the organizations such as the one we've seen will engage in. We expect that over the next 2 decades, the Atlantic Fellows Program will grow into a community of thousands. I hope that you will take a look at the pamphlet that was in your materials. We also have an atlanticfellows.org website, which explains the breadth and nature of some of those programs in very summary fashion. We hope that you will stay connected with that community and consider even applying for those fellowships. Success will take time. It will require changing policies and practices and cultural norms. We've talked about the narratives that should be addressed. You will hear more about that in a session later this evening for those of you who will be attending. We need to be able to engage in fresh thinking to sustain efforts at meaningful impact. And there's no better way to do that than to invest in the kinds of people whose work is evident in the kinds of award nominees we've seen. Chuck Feeney explained in his letter to the Giving Pledge that I can't think of a more personally rewarding and appropriate use of wealth than to give while one is living, to personally devote oneself to meaningful efforts to improve the human condition. Wealth comes in many forms. This room reflects great wealth of knowledge, of passion, of energy, of time, of dedication. And I have no doubt that the wealth in this room, dedicated to some of the challenges that we've been discussing today, will lead to a fairer and more inclusive world. I'm grateful for the opportunity to be able to support LSE in this community. On behalf of Atlantic Philanthropies, thank you for your work, thank you for your initiative, and we're excited about the prospects of these efforts going forward. Thank you very much.